Have you ever wondered about that machine you see in hospitals? The one that holds the line between life and death? The one that breathes for you when you can't? Well, today, we're going to demystify one of the most critical tools in all of modern medicine, the mechanical ventilator. It might seem simple on the surface, but its impact on the human body is incredibly profound and way more complex than you'd think. So let's start with this one big question. You might think a ventilator just pushes air in and lets it out, a simple substitute for our lungs. But it's not that simple. Not at all. It fundamentally rewrites the entire rulebook for how our body is supposed to work. So how does it do that? Well, to really get the machine, we first have to understand the magic of how we breathe all on our own. All right, let's get into it. Every single moment of your life, you're breathing. You don't even think about it, right? Your body has this incredibly elegant, super efficient system that just works. Now, here's where things get really interesting. This is the core difference. When you take a breath, your diaphragm drops down, creating this little vacuum that's negative pressure inside your chest, and that vacuum pulls air into your lungs. It's a gentle, natural pull system. A mechanical ventilator, it does the exact opposite. It's a positive pressure system that actively pushes air in. And trust me, that one little change from a pull to a push has massive consequences for your whole body. Okay, so let's zoom way in. Deep inside our lungs, we have millions of these teeny tiny air sacs called alveoli. Think of them like microscopic balloons. And inside, we've got a whole team of specialized cells. But the absolute hero of our story today is the type 1 pneumocyte. This little guy is on the front lines doing the heavy lifting of gas exchange that literally keeps us alive. But what happens when these little heroes are in trouble? I mean, during a critical illness, that whole beautiful, natural system can completely break down, putting the alveoli and the patient's life in serious danger. And this, right here, is the heart of the problem. When those alveoli get filled up with fluid or just collapse, that's a condition called atelectasis. Blood still flows right past them, but it can't pick up any oxygen. It's like a subway train speeding through a station with its doors welded shut. In medicine, we call this a shunt, and it's a fast track to total respiratory failure. And this is when a ventilator becomes absolutely necessary. Conditions like acute respiratory distress syndrome, or ARDS, and really severe heart failure, which we call cardiogenic pulmonary edema, they cause this widespread collapse of all those little alveoli. The body just can't get the oxygen it needs to survive. That's when we have to step in. So how in the world do we fix this problem of collapsing alveoli? Well, we use a really powerful setting on the ventilator that goes by a simple name, PEEP. PEEP stands for positive end expiratory pressure. Now, the key thing to get here is that this isn't about the breath in. It's a little bit of constant pressure that the machine keeps in the lungs even after you've breathed out. The best way to think about it is like a balloon. You know how it's easier to blow up a balloon that already has a little bit of air in it? That's PEEP. It never lets the balloon fully deflate. Yeah, the perfect analogy for PEEP is to think of it like an internal scaffold or a splint. It literally props open all those fragile, microscopic alveoli, and it keeps them from snapping shut at the end of every single breath. This gives them a nice, stable, open surface to do their critical job of gas exchange. And the benefits? They're huge, and they're almost immediate. By stopping that collapse, PEEP dramatically improves oxygenation. You've got more surface area for gas exchange, and it actually makes sick, stiff lungs easier to inflate. That's what we call compliance. Basically, it's a direct counterattack to that welded-shut subway door problem we talked about earlier. But, of course, there's a catch. There's always a catch, right? Pushing constant pressure into the chest just isn't natural. So this life-saving tool, it comes with some pretty big risks. It is a constant, delicate balancing act for the doctors and nurses. Now, what's really cool is that PEEP can sometimes help in unexpected ways. For patients with that cardiogenic pulmonary edema, remember, that's heart failure causing fluid in the lungs, the positive pressure inside the chest actually gives the struggling heart a bit of a break. It reduces the amount of blood returning to the heart, which is the preload, and it also lowers the resistance the heart has to pump against, the afterload. So it's a 2-for-1 deal, helping out both the lungs and the heart. So if it's so helpful, why don't we just crank up the PEEP on everyone? What's the downside here? Well, the very same effect that helps an overworked heart can actually hurt a healthy one. That positive pressure can squeeze the blood vessels, reducing blood flow back to the heart and lowering its overall output. And there's always a risk of overstretching and damaging the delicate alveoli. That's a lung injury we call barotrauma. It's an incredibly powerful tool that has to be used with surgical precision, which is why the goal is always to get the patient off the ventilator as soon as it's safe. And that brings us to the final chapter, the ultimate goal. See, mechanical ventilation was never meant to be permanent. It's a bridge to get you through the crisis. The final and most crucial step is getting the patient back to breathing all on their own. So, how do doctors know when a patient is actually ready? Well, they have a kind of checklist they run through. First, the original problem that put them on the vent has to be getting better. Their blood chemistry, like their pH level, has to be nice and stable. And most importantly, they have to show they can get enough oxygen with just a tiny bit of help and that they have a strong, natural drive to breathe. To help make this super critical decision, clinicians use this really clever tool. It's called the Rapid Shallow Breathing Index, or RSBI. It's basically a smart way of asking a simple question. Is the patient taking fast, shallow, kind of panicked breaths, or are they taking slow, deep, confident ones? It's just a simple ratio of their breathing rate to the size of their breath, and it gives us one number that tells us how efficiently they're breathing. And that brings us to the magic number, an RSBI score of less than 105. That number suggests the patient's breathing is efficient and deep, not rapid and shallow. It's a really strong sign that they're going to succeed once they're off the ventilator. It's one of the last big green lights on that path to breathing free. And the journey doesn't just stop when the breathing tube comes out. Doctors still need to check on long-term recovery using different lung tests. One of the big ones is called the DLCO. Think of it as a final report card for the lungs. It measures just how well they're transferring gas into the blood. It's a way to see how much healing has really happened and what the road to a full recovery is going to look like. So when you step back and look at the whole picture, you see what this machine really is. Mechanical ventilation is an incredible, life-saving bridge, but it's a bridge you have to cross carefully. So the central challenge that drives medicine forward is this. How do you build that bridge strong enough to get someone through the absolute worst moments of their life without letting the bridge itself damage the place they're trying to get to? It's a question that keeps pushing us to the very edge of what's possible.